Hi there, I'm Dr. Ed Levine, and I'd like to welcome you to the regional session for Wake Forest. We have a number of our team members here going to be talking to you about what goes on and how we put together our HIPEC team and how we take care of our appendiceal cancer patients. The key point I want to make sure everyone knows, whether you're part of the Wake Forest family in terms of being treated or from somewhere else, is that you're not alone, and there is support available for people who've got cancer of the appendix. So we're going to get started. I think the first person you're going to hear from several members of our team. First on the list is Stephanie Thornton, who is one of our nurse practitioners. She's been with me for a short decade or so, and we're together a long time. And she's got a number of insights. She's helped shepherd a lot of patients through the experience. So I'd like to thank you, Stephanie. Come on over and get started.
Thank you for that introduction, Dr. Levine. And as you stated, we have been together for a long time. So I've had the opportunity to really have an amazing mentor in Dr. Levine, and also having worked with Dr. Votnopoulos as well as you have spoke with earlier. And it has been an honor and a privilege. So how do I make this work? Right here.
You can do that, or there's right here you can use it.
Okay, got it. So welcome. I've worked for the department, the surgery oncology department for over 8 years. I provide care for our patients in a clinical setting and manage patients for pre-op and follow-up visits. Over those years, I have developed some standard recommendations for the most common questions and concerns for patients with appendiceal cancer and patients who have been treated with cytoreductive HIPEC surgery. All right. So the HIPEC stands for intraperitoneal chemotherapy. It is designed to be administered in a heated form, as you know. Following a CRS or cytoreductive surgery, the body undergoes many changes. These changes can be persistent based greatly on the extent of what is removed during the surgery itself. Here is a simple breakdown of the basic functions of the organs that are most commonly involved with the cytoreductive surgery. We have the small bowel. It is where digestion is initially begun. Excuse me. This is where your digestive enzymes are introduced, and they're responsible for absorbing most of the nutrients of the stomach. The large bowel, which is about 5 foot long, is responsible for producing and absorbing the electrolytes and storing feces. The omentum is adipose tissue, and it provides a protective lining. Thank you. I'm so sorry. And it provides limited peritoneal immunity and provides a protective covering for the organs. The spleen, which also contains white blood cells that help fight specific germs and infections, and it also helps to control the amount of blood in your body, destroys old and damaged cells. The gallbladder, which assists with digestion and storing and transporting bile. It helps to break down and digest fatty foods in the small intestines, and pancreas enzymes with the digestion and main management of your blood sugar. 85% of the pancreas role is to provide digestive enzymes. Most commonly used chemotherapy during a HIPEC is mitomycin C and oxaliplatin. Thank you. My screen is covering up part of the slide. I apologize. It is instilled through cannulas in the abdomen, and it keeps at a constant circulating temperature of about approximately 40 degrees Celsius or 105 degrees Fahrenheit. This is circulated around for about 2 hours here at the Wake Forest Center. Other centers may use different types of protocol. They're typically minimal Chemotherapy type side effects, although some can be noted, and most of the chemotherapy used in a HIPEC is washed out at the end of procedure. And within a few weeks, the remainder of the chemotherapy in a HIPEC has been excreted from the body. A single prospective randomized trial for appendiceal cancer has been performed, which found that mitomycin C and oxaliplatin have the same efficacy. An oxaliplatin HIPEC was slightly better during the first few months at quality of life. Management of a CRS issues are very commonly based for our concerns of our patient. Most of them are involved with exactly how much is removed and what types of post-operative issues that is concerned with. Your most common ones are digestive changes and changes in elimination patterns. After removal of the small bowel or large stab bowel, we do work with our patients to help maintain and give them more control over their bowel function. We utilize anti-diarrheas and fibers as the first approach to help control this, and we do this in an attempt and at a scheduled intervals to assist with giving the patient more control. This does help to improve their quality of life. We utilize a gradual step program to achieve that desired control, and it helps to also improve the absorption of nutrients, reduces the risk of dehydration and malnutrition, and as I stated, overall greatly improves the quality of life. Some patients do find probiotics helpful if their issues are not related to a reduced surface area issue. If the gallbladder is removed, of course, those are foods that are high in fat or more difficult to digest. If there is a portion of the pancreas removed, digestive enzymes and issues with controlling the blood sugar will be more, have more of an issue. Specific types of enzyme changes would require enzyme replacement therapy, and blood sugar changes can be managed with your primary care provider. It is recommended that you get a hemoglobin A1C at least once a year, and this is the blood test that helps provide a record of how well your pancreas is able to control your blood sugar for at least the last 3 months. Another important health management issue for patients who have undergone is the removal of the spleen. As I mentioned before, that the spleen helps to fight off specific germs and infections. Living without a spleen is safe. The spleen's duties are taken over typically by the liver and the lymph system and other organs. You should be given vaccinations at the time of your surgery and at your post-operative visit to help fight off pneumonia, both types of meningitis, and Haemophilus influenza type B. You should also receive a yearly flu shot and follow up with your primary care provider to get boosters for measles, mumps, and rubella, which is MMR, your diphtheria, tetanus, and pertussis, which is the DTaP, and these will help prevent any of the infections mentioned in the names. Booster shots are suggested every 5 years after your spleen is removed. Patients without a spleen are recommended to have COVID vaccines and boosters. So the health maintenance per the CDC dated on May 31st in 2023, the following are recommended vaccines and boosters. It is strongly recommended that everyone be vaccinated. The best vaccinations are the ones that are available for you in regards to the COVID vaccines. These are if you're 65 or older. Of course, if you live in a long-term facility or assisted care retirement community, work in a high-risk setting, have other chronic underlying conditions such as recently received systemic chemotherapy, you have a cancer diagnosis, you do not have a spleen, you have other long-term or chronic conditions of the heart, lungs, kidneys, or the liver, or you are diabetic, have a compromised immune system, or you are a transplant recipient. If you only got the original COVID vaccines, you should get 1 to 2 updated vaccines, then an additional one later on that later that date. For women who have had their ovaries removed, gynecologists should discuss with you hormone replacement therapy. For patients, hormone replacement therapy is safe. Anytime that you have your ovaries removed from that point at 5 years later, you should be getting a DEXA scan. That does allow you to keep on the health of your bones. And you may need to use therapies to help concentrate the calcium back in your bones, which can be discussed with your primary care provider, your GYN, or an osteoporosis specialist. Mammograms every year are recommended at the age of 40. Continue with your pap smears based on the guideline uses, and a hysterectomy have been performed to discuss with other gynecologists. There we go. Long-term health management is a priority of our patients. Weight management, regular exercise, high-quality nutrition, as well as proper hydration help to provide excellent health management, avoiding tobacco and excessive alcohol use. A colonoscopy every 5 years is recommended for all fit appendiceal patients. Regular yearly checkups with your primary care provider remain important. Oncology follow-up should not be in lieu of your regular primary care visits, but as a supplement to them. Long-term health management also includes doing all of the things that make you happy. This provides for important health, mental health management, and creates long-lasting memories. Most important is the routine follow-ups with scans, blood work, and your surgical oncologist. This allows them to monitor you properly and to provide with the best recommendations needed. Thank you for having the time to speak with me today. And more importantly, thank you for having us to be involved in your care. I hope the information that I have provided will answer some of your questions and also gives a framework to manage in your overall health needs.
Hi, I'm Monica. I'm an inpatient dietitian at Baptist Hospital, cover the HIPEC patients. I just wanted to talk today about nutrition in HIPECs. Wanted to talk about nutrition before and after surgery. So starting off, before surgery, it's good to make sure your weight is maintained. And if you're underweight, you want to make sure you gain weight. If you're having any difficulty with eating, any trouble with weight gain, or weight maintenance, then we do have two outpatient cancer center dietitians, Wendy Watson and Emily Henderson, which are great to talk to. I would just ask your doctor to send out a message to them, a referral for you to see either of them. But I just want to talk about some best food choices that are good for before surgery, just for good general health. So eating a variety of fruits and vegetables, getting different colors to get different antioxidants, eating whole grains, getting your legumes, your nuts, your eggs, your fatty fish, like salmon is a great option, and low-fat dairy. And then some things that are good to avoid or at least limit processed meats. And you do want to limit red meats to no more than 18 ounces a week, which, to give you a frame of reference, 3 ounces is the size of a deck of cards, which is, a fairly small amount. But that just will help you know how much 18 ounces is. And also I would avoid or limit at least refined grain products, and that would be things like white bread, white pasta, white crackers, all that the grain, the fiber is stripped away. And also I would limit any added sugars. And that would be like desserts and sweetened drinks. supplements may be helpful to help with weight. And especially if you're having trouble with weight, the Ensure Plus, the Boost Plus will give you more calories. There's some Orgain supplements that can be helpful for calories. That's what you need. You're gonna want, vitamins and minerals, protein, and everything, but calories are gonna help with that weight. So some of the lower calorie supplements may not be as helpful. If you do have a partial intestinal obstruction before or after surgery, it's good to limit the insoluble fibers, things like nuts and seeds and raw fruits and vegetables, except for like bananas are okay. This is not an evidence-based diet, it's an anecdotal diet. So there's not research that backs it up. But if limiting the insoluble fibers isn't helpful enough, then I would just change the consistency of the diet to getting softer, like soft foods, to pureed consistency, to even liquids if needed. If, solid foods just still a struggle. I want to talk about sugar because a lot of people are concerned about sugar. And consuming carbohydrates, but complex carbohydrates are definitely healthy. What I would do is just limit the added sugars. So any of the sugars that are added to drinks, to foods, not the naturally occurring sugars, because sugar is, every cell in your body actually uses glucose for energy. So if you're not getting enough carbohydrates, you're going to be low in energy. Your body's going to break down proteins instead to get energy. So, it's like your car needing gas or electricity to run, like your body needs it to run. So again, I would choose the complex carbohydrates, the whole grains, the fruits, the starchy vegetables, and limiting those things that have those added sugars. So sweetened drinks, desserts, anything else, like if you're getting canned fruit, limiting canned fruit that has and syrup, limiting any of those sugars like that. Now, shifting gears to post-surgery, your diet after surgery is going to be determined based on whatever resections you have done. So it can vary from person to person. You may not have any diet restrictions at all after surgery. If you have a significant amount of your stomach resected, you're going to have some restrictions. If you have a large amount of your small intestines removed or not that much left, then that can change your diet for sure. If you have your gallbladder removed, you might be sensitive to fats. You might want to just reduce your fat intake. But that will really depend on how you do with it, how you do with fats if you have your gallbladder removed. And when it comes to calories and protein, there's no one size fits all. Your needs are going to just depend on your height and weight, your medical history, your weight history. So if you want to know your needs, and if you're inpatient, I can come by and talk to you about what your goals would be. I can calculate that out. If you're outpatient, then you can get in contact with outpatient cancer center dietitians, and they can talk to you about that since I'm inpatient. After surgery, the goal is to, if you did have a bowel resection by day 3, you'd be on a full liquid diet, which would be anything in liquid form. And by day 4, you'd be on regular consistency foods. If you don't have a bowel resection, you would be on a full liquid diet by day 2, and then a regular consistency diet by day 3. But if you do have complications, like you don't tolerate the diet well, or your nasogastric tube, you have a lot of output, then you may not progress like that. And if you're struggling to eat once you're on a diet, supplements may be helpful. Now, your protein needs are going to be higher after surgery because you need the protein to heal. So I would make sure to include a high protein source every meal and snack. So things like meats, chicken, turkey, beef, fish, that's all protein, nuts and nut butters, eggs, legumes, beans, yogurt, milk, cheeses, all of those things are high in protein. And some benefits of having good nutrition after surgery would be that you're going to heal quicker. You're going to have less complications after surgery, less chance of infection, less chance of pneumonia, less chance of having an ileus, which is your intestines not waking up fully, decreased hospital length of stay, decreased chance of hospital readmissions also helps, nutrition helps with. And I just want to talk about some symptom management because you can have some symptoms with, peritoneal cancer before surgery and after the HIPEC, you might have some issues. So some common symptoms that I see are abdominal fullness or bloating. What I would do is make sure you're avoiding any gassy foods and avoiding ingesting air. So what I mean by that is like avoiding using a straw when you're drinking because you might suck up more air, or avoiding talking while you're eating because that can cause you to suck up more air, avoiding carbonated beverages, and also the gassy foods. Common gassy foods for people are broccoli, cabbage, beans. It can be a variety of different things. Onions could be an issue too. There's a variety of things can be gassy foods, but whatever was more common gas forming food for you, I would just avoid if you're having fullness, bloating issues after surgery or even before. And eating small, frequent meals and snacks can be helpful too. And another symptom that you may have is nausea. So eating dry, starchy, bland foods can be helpful, like crackers, toast, dry cereals, chicken noodle soup. Alternating your liquids from your solids food. So just having liquids in between your food, avoiding sugary, or at least diluting sugary drinks like regular Gatorade and juice, or sugary drinks. So like doing half water and half juice can be easier on your stomach, especially with you have an empty stomach. That can be hard on your stomach. Eating small, frequent meals and snacks, avoiding pills on an empty stomach unless your doctor specifically says that you need to take that specific medication on an empty stomach. I would take nausea medication as soon as you start to get nausea because that could get worse and hard to control once it gets going. Rinsing your mouth out or brushing your teeth before and after you eat is helpful. Sitting up in the bed or chair for at least 30 minutes to an hour after you eat can also help. Just help things go down the right way. And then making sure that nausea is not from dehydration. So staying hydrated, sipping on some clear liquids every 15 to 20 minutes as you're able to. And then diarrhea is also a problem that can happen. So trying to do small frequent meals and snacks can be helpful with diarrhea. Consuming your liquids again in between your meals and less at the same time as your meals can be helpful to just slow down digestion. And then avoiding sugary foods, because sugary foods can also just make things go quicker, cause you to have more fluid in your digestive tract to make things pass faster. So avoiding those sugary foods, those sugary liquids, avoiding sugar alcohols. So if you're doing sugar-free foods, gums, candies can have sugar alcohols like xylitol, mannitol, sorbitol. And then also the high sorbitol fruits. There's the pea fruits, the pears, peaches, pineapple, and prunes are high in sorbitol. So I would stay away from them if you're having diarrhea. And then you can also try just decreasing your fat intake. So avoiding fried foods and avoiding foods with a lot of oils, butter, cream, a lot of cheese that can help potentially with diarrhea. And then eating some starchy foods like bananas, white rice, mashed potatoes, oatmeal, crackers, some of the rice cereals, that stuff that can help give you some soluble fiber to slow things down. And then, lactose could potentially be an issue. So limiting lactose foods, which would be milk containing foods like cheese, pudding, ice cream, you can always try lactate, which is the enzyme, or lactase is the enzyme that breaks down the lactose, which is the sugar in milk. So taking that with dairy to see if that helps, especially if you notice having diarrhea specifically after dairy intake and getting bloated and gassy after that could definitely be lactose intolerance. And again, you can just take the enzyme with dairy. You don't have to avoid dairy completely. And so I just want to say before I end, again, that, if you're having problems after your hospitalization with weight and struggling with eating and having any of those symptoms, you're just struggling and not being able to eat well, I would have your doctor reach out to the outpatient cancer center dietitians, Wendy Watson or Emily Henderson, to talk with them and try to get help. If you're having any problems while you're inpatient, then I'm the one that's around here to be able to help with that. But hope everything goes well for you, and I hope this is helpful. Thank you.
Our next presentation again from Nathan Ogilvie, who worked with us on the inpatient side. He's been working with us for a couple of years. He's a physician's assistant who's been working with us. And I think he's actually got some action sessions about ERAS.
Hello, my name is Nathan Ogilvie. I am a physician assistant with the surgical oncology department at Atrium Health Wake Forest Baptist Hospital. And I am here today to talk to you about enhanced recovery after surgery, improving patient recovery. We've heard a lot of presentations today about the science of peritoneal malignancies, including how to best target these, and then tumor and patient-specific things that we are learning about tumors to help us improve outcomes. But the science doesn't stop there. One of the other things that we are looking at as well is how patients recover from these operations. And that's one of the things that I wanted to take a look at today. When we developed this protocol, we looked at our own patient experience as well as the patient experience of other centers that provide HIPEC. And we looked at these together and came up with this enhanced recovery or after surgery or ERAS protocol in order to improve patient outcomes. So if you've had this surgery, your patient experience has been part of our journey in developing this pathway. So in a case like that, we wanted to say thank you. So what is enhanced recovery after surgery, or ERAS? What ERAS is, it is a multidisciplinary, evidence-based pathway that we've put together in an effort to move patients efficiently and safely through the recovery process after a cytoreductive surgery with HIPEC. Well, the objectives of these ERAS pathways are not unique to HIPEC surgery. This is something that's been done throughout this country and throughout the world, really, in regards to recovering patients from surgery. And these are used in all manner of different surgeries. So the objectives of these ERAS protocols are to reduce length of stay, to reduce patient complications, to reduce cost, and additionally to improve patient satisfaction, especially when you're dealing with a teaching hospital where there are a lot of different providers and people taking care of patients after these surgeries. It helps to have a pathway that's laid out for all of us to be on the same page in an effort to help patients recover in a very uniform fashion, no matter who is on that team. So what is involved with, or what are the elements of enhanced recovery after surgery, or ERAS pathways? They really involve multiple things, but I've consolidated it down to these 5 elements. It involves ambulation, as well as nutrition, early nutrition, management of IV fluids, management of pain control, as well as management of tubes and drains. And these surgeries are very large surgeries, and they often have lots of tubes and drains associated with them. So when a patient is recovering after surgery, one of the challenges is that on average, most of our patients will stay about a week, sometimes a little bit longer. And one of the challenges is what is the right time to send the patient home? We frequently will tell the patient they'll be here anywhere from 7 to 10 days, but often on the patient side of things, the discharge date can be something that is almost cryptic, like we are waiting for this moment at which they can go home, as though it is not a very deliberate date. With an ERAS pathway, one of the things that we sought to do is to bring patients as well as providers onto the same page as we move patients down a very well trodden pathway, so that the discharge date is something that is very predictable. It is something that we see coming, and that we all are involved with getting the patient prepared for that date. So it ends up being a safe and an exciting date for that patient. So how do we select this, or how do we move patients down, or what elements to have on these ERAS protocols? And we know that after surgery, that a patient's ability to go home is predicated off of these 5 elements. First and foremost, that they're able to be up and safely moving about. 2, that they're eating and drinking well, that they're able to sustain themselves at home without supportive measures. 3, that their symptoms are well controlled with pain and nausea, and that involves getting them on something that is oral so that they can further manage those symptoms at home. And then bowel and bladder function. Frequently, our patients will have ostomies, and so this can be variable for patients, but generally speaking, we just need this element of a patient's recovery to be something that is well managed and that we've got under control. And then lastly, which is a little bit of a grab bag, that there's no other concerns for the patient, that all the tubes and drains that need to be removed have been removed, that there's no infectious concerns in regards to the patient's incision, as well as overall recovery from surgery, as well as we've removed all the supportive measures that they've been appropriately weaned off, such as oxygen and IV fluids. So when we look at this, most of our patients will stay anywhere from 7 to 10 days. Our own experience at the Atrium Health Wake Forest program for HIPEC is on average about 8 days as patients will be. I've only set 7 days onto this slide, just simply because, as you notice, from really day 5 on, it's just simply buttressing up each of these elements of the patient's recovery. So how do we progress patients through these 5 elements that we've looked at? First off, with activity, is that we get patients out of bed early, and we like them up and ambulating by day 2. In regards to diet, you'll notice BR and no BR, and that stands for bowel resection. And for patients who've had a bowel resection, we often will leave the nasogastric tube 1 additional day. And when they've not had a bowel resection, we attempt to get the nasogastric tube out on day 1 so we can get them onto some liquids. In regards to IV fluids, we immediately on post-op day 1 start reducing IV fluids down in an effort to minimize some of the complications that go along with the patient getting more IV fluid than what they need. And then pain control. We frequently will employ epidurals, but often we'll additionally use PCA pain pumps to assist. But usually once a patient is on a regular diet, you'll notice that we are now making that transition off of that supportive pain control with an epidural or a PCA onto something oral that we can send a patient home with. And those final days, day 5 through day 7 or 8, as it may be, we are simply titrating dosages so that a patient going home knows that the oral regimen we're sending them home with is sufficient for them. And then lastly, with drains and tubes, we are on day 1 taking these tubes out as they are no longer providing a benefit either from a monitoring or supportive standpoint. We look to get these things out as soon as possible. So in regards to activity, this is probably one of the key elements with an ERAS protocol, as the patient and the provider need to be on the same page. Oftentimes when we're coming in and getting patients up and about on day 1, how the patient feels and how we feel as providers, we're very enthusiastic, but the patient oftentimes can feel like that's not the right time. And what that ERAS protocol helps with is getting us both on the same page. We know in regards to a patient's activity that a moving patient is a recovering patient, and there are a lot of downsides to an immobile patient in recovering from a large surgery such as this. We know that from looking at a lot of the data, not just from surgical data, but hospitalization data and our own data in regards to HIPEC surgery, we know that for each day a patient spends in bed and not mobile and up and about, that can add length of stay, sometimes even doubling that length of stay. For every 1 day a patient is in bed, it often can lead to 1 additional day of hospitalization and up to 3 additional days of rehab if a patient is going to a facility. So getting a patient up and moving early on in the recovery helps with maintaining strength, improving return of bowel function, reducing the likelihood that the patient will need an additional stop before going home, and then also eliminates or minimizes the risk of all the complications that go along with a patient being immobile, such as pressure ulcers, pneumonia, blood clots, as well as falls due to weakness. And then an often overlooked element to a patient's recovery is sleep. When a patient is in bed sleeping most of the day, it makes nighttime a very difficult time to sleep. And so getting up and moving is something that helps with patient sleep. Next element is diet. And oftentimes a patient is very excited to get back on a diet, but realizes that as soon as they start attempting to do that, that oftentimes what seemed like a joyous occasion can often be a very overwhelming thing as they look to get back onto some food. We do know that rather than what we used to historically do, which was to wait until a patient has return of bowel function, is that early initiation of a diet and minimizing nasogastric tubes oftentimes can stimulate return of bowel function a little bit earlier. We do know this from colorectal surgeries experience, that we don't necessarily need to keep patients nothing by mouth for several days after surgery. Early initiation of a diet improves healing, reduces risk of infection as the patient's own immune system is able to function better. It helps to mobilize fluid. Oftentimes there's a lot of swelling that goes on into having these surgeries. And by doing that, patients are up and moving, and it improves a mood and sense of well-being. The next element is minimization of IV fluids. And this may be not something that is always cognizant to the patient, but something to us as providers is reducing IV fluids as soon as is safely possible. We know that more patients' recoveries are impaired by too much IV fluids than they are impaired by not enough IV fluids. IV fluids contribute to swelling, which reduces mobility, also slows return of bowel function, can provoke heart arrhythmias like atrial fibrillation. So often what seems like a very benign thing can often get in the way of a patient's recovery. So part of an essential element of ERAS recovery is to get patients off of IV fluids as quickly as possible. The next element is pain control, and this is something that has been a very large topic, as we know that there are all sorts of downsides. Narcotic pain control, although pain control is essential to recovery from surgery, we know that we can do better than simply providing lots of narcotic pain medication, as narcotic pain medication increases nausea, it's sedating, it slows return of bowel function, it has some habit-forming potential risks for patients. So we know that the best we can do is to use as little as possible to get the best effect as possible. So an ERAS protocol, one of the elements of that is getting patients off of the oral narcotic pain medicine or IV pain medication and use other multimodality pain control elements, such as nonsteroidal anti-inflammatories, use of acetaminophen, muscle relaxers. These things often placed on a patient in a scheduled fashion will minimize the amount of narcotic pain medication and will speed along a patient's recovery. So we will employ these as part of our ERAS protocol. And then lastly, that minimization of tubes and drains. Drains and tubes, they're tools. We use them to monitor what's going on in the abdomen. Sometimes we will use them to help reduce the amount of fluid buildup in a patient after a large surgery. And we know that these things impair mobility. They often add to pain control issues, as well as they pose some infection risk and bleeding risk. And therefore, by eliminating these tubes once they are no longer providing a stated or a specific objective to a patient's recovery, we get these out as quickly as possible. And so when you look at all these elements together, these make up the key elements of an enhanced recovery after surgery or an ERAS pathways. And our hope here is that these will speed along patients' recovery, reduce length of stay, reduce patient complications, as well as improve a patient's recovery experience, as they are no longer passive observers in the recovery, but are rather, they are an essential part of their own recovery, and they're partnering with their providers to speed things along. So I appreciate the time that you've given me to discuss this, and I thank you for that. Thank you.
Thank you, Nathan. So let's go to the interview, which is actually kind of nice. This is someone who has been with us, and I think he's got quite an interesting story to tell. I think you'll find it as motivating as we did.
Spencer Lewis joins us today, diagnosed 32 years ago with low-grade appendiceal cancer. In 1999, he received his first HIPEC and cytoreductive surgery via Dr. Brian Logie in Omaha, and he did very well for many years and required a second HIPEC and cytoreductive surgery via Dr. Levine in January of 2021. He now continues with annual surveillance, and that includes CT imaging and labs.
In 1999, I had a routine hernia repair, and when I woke up from that surgery, the surgeon told me that he had found this gelatin-type substance in my abdomen, and it was not normal. That raised some concern to me, of course, and through review and consultation, I was referred to Baptist, and I was diagnosed with the pseudomyxoma parentae. I met with Dr. Logie, and he explained what my condition was and what my options were. And I remember asking him, this sounds really complicated and really difficult. What if I didn't go forward with it? And he said, you would die in about 1 to 2 years, a very painful death. I said, okay, I will go forward with it. I was 34 years old, and I was blessed to have Dr. Logie and Baptist Hospital as an avenue to do that, because in my original diagnosis, there was very few options available, and it was gut-wrenching. It was a wake-up call. Initially, I was having a hard time accepting the diagnosis. I was angry. I was in denial. I was angry. You know, surely there must be a mistake. Surely there must be a misdiagnosis or a wrong person's chart. I didn't do anything to deserve this. It's unfair. Those types of things. And I've worked my way through that to accept the fact that there are many things that are not in our control. And we do our best to adapt. And my family has been very supportive. We don't take time for granted. When you have this kind of diagnosis, it puts an urgency on what you want to accomplish, and in what time frame, and that you might need to adjust that time frame. And when I first had the surgery done, I was younger, and I was in the hospital about 7 or 8 days. Got out, and I was plagued with nauseousness. And it was difficult because I was trying to eat, and I didn't feel like eating, and anything I did eat would not stay down. And so it was a difficult recovery in that regard. I did find that my waistline was getting a little bigger, but I thought maybe that had something to do with getting older or things I was eating. I really didn't have any signs of organ involvement or dietary restrictions or anything like that. In 2020, I was diagnosed again with pseudomyxoma parentae, and I was shocked because I was told by my primary care that after 5 years, if it didn't come back, it would never come back. So I did not have any routine monitoring, and I felt good, and I was active and continued to work hard and all those things. And I then began to experience abdominal symptoms that were definitely abnormal for me. And one thing led to another, and I was referred back to Baptist. That condition was much more advanced the second time because I had not had any monitoring, and it was actually symptomatic at that time. I couldn't process food. It got to the point where I couldn't eat certain types of food, such as popcorn, such as potatoes, such as bread. Anything bulky I could not eat. I could eat it, it would taste good, but it wouldn't go further than my stomach. And then I had a lot of abdominal pain, vomiting and such, and basically my intestines had been strangled by a gelatin type tumor. That was much more serious. I was afraid was going to be the end of me because I couldn't eat. I was losing weight by the day. You know, a pound, at least a pound a day, I was losing weight. And I have a very fast metabolism. And if I don't eat on a regular schedule, I lose weight. And in that type of condition, it was very scary. And so the surgery was much more extensive. You know, they had to remove some more intestine from what they removed in 1999. And the recovery was harder the second time only because I was weaker and I hadn't been able to eat on a regular basis leading up to the surgery. Having your intestines spliced is difficult to the fact that you're not there, you know, you're under anesthetic, so you don't see what happens. All you know is that you wake up and you want to try to resume your regular diet and your activity, and it's trial and error. After about a week of those conditions, I was so proud of myself. I was able to eat one small saltine cracker and keep it down, and then I just worked that small saltine cracker into. Then the next day I had 2 crackers, and then on the third day I had 3 crackers with a slice of cheese, and then my diet just gradually increased from there. I stayed away from foods that were greasy and had a lot of gravy, spiciness. You know, I had to stay away from. So I've had to alter my diet even since. You know, I can't return to a complete pre-surgical diet of what I used to eat. But because in the surgery, it's not just your colon or your intestines that are being worked on. There's usually ancillary organs that are removed, such as your, well, of course, the appendix, but you have your spleen, you have your gallbladder. Those things affect your ability to process food. So it's not just your colon, it's the other things as well that will affect your ability to be able to process food and to be able to feel better and have energy. I would consider my quality of life very good. I've been able to return to all the pre-surgical activities, though I do have to take things a little slower and I have to think forward, but that's also, you know, I'm also getting older. So I'm not 25 anymore, though I still ride my motorcycle, go on trips. Most of my activities I've been able to do. After the first surgery, I haven't done it just after the second, but I took up skydiving, so I was skydiving after the first surgery, and I haven't tried it after the second surgery, mainly because my schedule is so busy. So I have a pretty active life. I have a full-time job, I have a part-time job on top of that. I volunteer at the church to serve the community and the soup kitchen. I'm pretty active, and I like to stay active. I do, yard work. I'm able to work on the cars, so I'm able to do pretty much everything that I had done, prior to the surgery. Well, Wake Forest Baptist has a very, very good reputation for excellent care, and when I did the consultation with Wake Forest, I saw how professional it was, how advanced the medicine is. The training to the staff, all the staff knew what they were doing, were competent, the surroundings were clean. I can tell it was a well-oiled machine. During my recovery, the nursing staff is phenomenal. They are second to none. I cannot say enough good things about them. I would like to thank my care team for this. First of all, Brian Logie, Dr. Logie, for doing this and accepting me into the program. For Dr. Levine, basically saving my life. He basically did a phenomenal job that many doctors, I understand, probably would not have done. So I thank him, and I thank all the nurses and the staff and everything. Everybody treated me with compassion and respect, and with the utmost intention for me to get better as quick as I could. I would recommend the HIPEC procedure. It is life-saving. It has saved my life twice and allowed me to maintain a good quality of life and continue to spend time with my family and go through life events. What I would recommend if someone is diagnosed with this is first determine or come to the realization that it's not your fault. You didn't deserve it. Bad things happen to good people every day. Don't blame yourself. Don't be angry with other people. Don't lose your faith, and just adapt to it and try to get through it with determination. Use that anger or that hurt as a determination to get better and resume your pre-diagnosis quality of life.
That's a spectacular story, and we're pleased, very pleased he was willing to share it with us. I think it's terrific to hear what goes on and the patient perspective. You heard a lot of talk during the course of the day about what happens to patients, the science. To hear it from the patient's perspective, somebody's actually been there twice, is truly remarkable. And I very much appreciate him taking the time to share a story with us. Now, the last presentation we're going to have, and unfortunately we're running late, so I don't think we're going to have time for the Q&A at the end of this session. And this now is for Rebecca Harmon, who's our nurse navigator, who helps coordinate a lot of our activities with other things that go on and getting patients to where they need to go. And can we hear from Rebecca, please?
Hello, my name is Rebecca Harmon. I am the GI colorectal oncology nurse navigator at Atrium Health Wake Forest Baptist.
Sorry about that.
And a lot of people ask this question, what is a nurse navigator? A nurse navigator is a registered nurse with oncology specific knowledge who offers individualized care to patients throughout their cancer care journey. We work with the team to help provide better patient outcomes. We definitely use a team-based approach to help patients through the healthcare system, make sure they understand their personalized care plan, and overcoming any barriers to you getting the care you need, and just make sure that you have someone by your side to steer you through the entire journey. A nurse navigator wears many hats throughout this process. We help with timely access to care, coordinating and scheduling appointments, and making sure we have all of your medical records to review. We provide education on your specific disease process, go over expectations about your treatment plans, side effects, and how to manage those side effects. We provide information regarding supportive needs, resources. We help facilitate communication between the healthcare team. We always support the patient in their decision making. We want to improve this process for the patient and their families. So we always want to make sure the patient is forefront. And we help answer questions throughout this process, just according to your specialized plan of care. So this is a very overwhelming process. So barriers do come up, but that is something that the nurse navigators help with. A lot of our common barriers that we see is transportation issues, social and cultural disparities, lodging needs for patients and their families, because a lot of our patients do come from out of state, and financial concerns. As I said before, we do use a team-based approach. So as a nurse navigator, we refer out to other supportive services. One of the referrals that we can place for our patients is to the financial navigation department. These financial navigators help patients navigate through the financial process of a new cancer diagnosis. They help reduce stress related to the cost of treatment. They also see if grants are available to help with patients. They help patients understand their out-of-pocket expenses, what their insurance plans will cover, utilize copay assistance and patient assistance programs to assist with those barriers. Also, with our team-based approach, we have a group of population health navigators. They are bilingual, culturally concordant. They're a generalist multi-disease patient navigators. We have the underserved populations like Hispanic, rural, African American, and young adult populations. They are non-clinical, so we work with them. We as nurses do the clinical side and they do the non-clinical side, but we work as a team to make sure the patients have the best journey and understand kind of what the expectations are and to make sure they are supported throughout this process. They focus a lot on social and emotional needs. They can provide clinical trial education, community outreach, and engagement, but they are a very important part of our multidisciplinary care team. So additional resources, we always empower patients to ask questions. We are here for you throughout this process. We also have a HIPEC ambassador program where we can connect patients with past patients who have had similar experiences. This really does help to form a relationship with them and help them just feel better about this process. We can assist with finding organizations that provide up-to-date support and resources. And we also encourage people to get involved with a local support group, and Facebook has a lot of great specific groups regarding the HIPEC program as well. Not only is the patient an important part of this process, but the family and caregivers also need support. So there's a couple different websites listed. The National Alliance for Caregivers and also American Cancer Society have great support for the caregivers that are also going through this process. And just remember, you are not alone. We as nurse navigators are here. We want to empower patients and their families and just be a support for you throughout this process. So thank you very much.
All right, thank you. Again, we're running over time. We appreciate your patience. Thank you for joining us today. On behalf of the entire Atrium Wake Forest HIPEC team, as well as for the ACP-MP research, I'd like to thank you for joining us today. Hopefully we'll look forward to answering any questions you might have. Feel free to reach out to us on the team. And do keep in mind when we go forward that you are not alone. We are here to help you, and we've got all sorts of opportunities to intervene and to make things easier for you. Thank you for joining us. Have a good day, and we are adjourned.